you guys for having me. Yeah, I was at National for like 13 years, teaching DC students and the radiology residents. One of the things that I had trained in and learned while there as a professor was musculoskeletal ultrasound and how it really is beneficial for the chiropractic practice. And I wanted to just take this hour and run through some of the basics related to musculoskeletal ultrasound, when it's appropriate, when other imaging modalities would work, and when you are looking at an ultrasound, what are the benefits of it? What do the tissues look like? And then I'm going to share a couple cases that I had come across over the years. So, brief history of ultrasound. I know that's not super exciting or germane, but it kind of gives you an idea of how long this modality has been around. This is not something that's come up in like the last 20 years. This has been, well, as the slide you could see, first time sound waves, so to speak, were used in imaging was in 1942 when a neurologist was trying to use them to locate brain tumors inside somebody's head. First time actually musculoskeletal ultrasound was employed was in 1958, and actually that Dr. Dusick, I'm sure I butchered that name, but he was the first one to actually kind of map out what the normal appearance of normal tissue looks like using an ultrasound machine. And then again, the first published case of musculoskeletal ultrasound was in the British Journal of Radiology in actually 1972. And it was basically a case where they demonstrated using ultrasound to differentiate a Baker's cyst behind the knee from thrombophlebitis, which is actually an application that's still used today. Funny enough, happens a lot in imaging. The big profession that was really used musculoskeletal ultrasound a lot was the rheumatology profession. And what they were doing was using the ultrasound scans to look at the thickening or the synovial lining inside a joint. Patients with an inflammatory arthritis like rheumatoid, you would get a lot of hypertrophy in that synovial joint. And they were able to see that with an ultrasound scan. And then they were able to track the thickness of the synovial layer in response to the medication. So they were using it pre and post treatment to see if there was an actual physiological response from the medication that was being used. Then started getting used in the shoulder in the later 70s. In the 80s, they were using ultrasound to guide injections, stick needles into joints, instead of going blind or actually using fluoroscopy, which has radiation. They were using ultrasound. And then, of course, they were bringing power Doppler into the equation as well, which was showing hyperemia. And I have an example of where that's used coming up later on. Today, again, rheumatology is still using it a lot. It's routinely used in monitoring synovitis. It's actually 7 times more sensitive than X-ray if you're looking for subtle rheumatoid erosions. They're using it for guided injections again, or aspirations, inflammatory arthropathies, muscle and tendon abnormalities. And a big one here that I have, wish I can get my laser pointer out. Give me a second. This is a big one that I'll talk about, nerve compression syndromes. It's one of the few modalities where you could really pick up subtle nerve compression syndromes all over the body. Obviously, we jumped a carpal tunnel is a big nerve compression syndrome, but they're all over the body, a tarsal tunnel syndrome. Yeah, I don't know why that's the first one that popped off my head, but any kind of nerve compression syndrome can be picked up with ultrasound. And then again, as the technology advances, you're going to continued improvement of the modality and how it's going to be used in practice. In terms of its usage, this is the big thing that I've even seen I'm in the Chicagoland area, and what we've seen around the Chicagoland area, it's big in podiatric medicine. It's huge. That's probably made the biggest leap. It's also big in our profession as chiropractors. I can think of a number of chiropractic schools that features musculoskeletal ultrasound. I learned it at National. I think the first big school to really incorporate it formally was Logan, but I know Palmer and Davenport has it. I know it's out in the Pacific Northwest. So all the chiropractic schools, at least my colleagues, DACBRs, a lot of us have the RMSK certification because it is becoming more and more prevalent. Okay. So some of the pros to ultrasound, why would you choose it as a modality? Well, first off, it's inexpensive. It's inexpensive for the patient. To purchase one of the machines is not the cheapest thing in the world. But for the patient, from a patient standpoint, it is inexpensive. I think reimbursement for an ultrasound scan, an MSK ultrasound scan, is going to get you anywhere in the neighborhood of 60 to $100 is what I've heard insurance is really reimbursing nowadays. You get it's a fast exam, you get immediate results. Patient preference is actually very, very high with ultrasound. Most people would they'd rather sit in a chair or lay on an exam table and have the ultrasound probe go over the area instead of getting stuck in an MR machine with a big coil around it. And that's, again, I want to preface this is not going to replace MR at all. But there is a little bit of patient preference for this scan. With certain parts of the body, there is higher resolution. Ultrasound allows you the opportunity to do dynamic assessments of joints, which is kind of unique to this imaging modality, as well as sonopalpation. All sonopalpation is if you have the probe over the painful area, say you're looking at a cyst, you could compress those tissues and see if it actually does reproduce the symptoms that the patient is complaining about. Again, that's another feature that is unique to this modality. You can't get that with an X-ray or a CT or an MRI. And when it comes to ultrasound, there really is no contraindication to it. It's a really, really benign modality in that regard. If you have patients that maybe have contraindications to, say, an MRI because of a cardiac pacemaker or surgically implanted devices that are not MRI compatible, an ultrasound is an option for you, specifically what you're looking for, depending upon what you're looking for. What are the cons of ultrasound? Well, it's only good for visualizing the periphery of a joint. If you have a deeper structure, depending upon the thickness of the patient as well, it might be hard to maintain that resolution and actually visualize some of those structures. A lot of protocols are under development, and it's very, very, very operator dependent. Probably the most operator dependent imaging modality that exists. A lot of X-ray, CT, MRI, the technologists are highly trained in it's very reproducible. You order an MR scan, you order an MR scan of the lumbar spine, you could send it to 4 different imaging centers and you're going to get very, very similar results. I could order an MSK ultrasound of the shoulder to 4 different people, and I'm going to get a wide variety of results in terms of from a technical standpoint. So it's very, very operator dependent. I personally would rather do the scan myself and know what I am looking at. And if you ever did get into this as an option, an imaging modality that you would consider using, you'd want to do it yourself to make sure you know exactly what you're looking at and you see how the patient responds, depending upon where that probe is. Or you find an RMSK that you trust to get you good quality images. Another con of ultrasound is surgeons are going to want an MRI. I've got a number of cases in here that I show the abnormality on ultrasound. It went to a surgeon and the surgeon ordered the MRI, and you see the exact same thing. But most surgeons, when they went through the residency that are in practice now, they learned or were taught to do the operations based on an MR appearance, not an ultrasound appearance. So they're not very comfortable operating from an ultrasound scan. Now, I have heard younger surgeons that are out there are being exposed to musculoskeletal ultrasound more and more. So you might find a surgeon that's willing to work with it, but I would say the vast majority of them are more comfortable operating from the appearance on an MRI instead of a musculoskeletal ultrasound from a preoperative standpoint. Okay. And then again, there's a lot of low-hanging fruit if you ever felt like getting into research and using musculoskeletal ultrasound. There's a lot of it out there, but I mean, compared to other imaging modalities that exist, you just don't see it. Now, ultrasound compared to MRI. Ultrasound with certain parts of the body, it does have superior spatial resolution. And something that is unique to ultrasound is you could visualize soft tissue structures like tendons and ligaments in a dynamic situation where you could move the joint and you could actually see ligaments or tendons sliding back and forth. You can't do that with any other imaging modality. With fluoroscopy, I could see bones move, but I can't see ligaments or tendons moving, and I can't assess really stability. Okay. Ultrasound's cheaper. The equipment is actually cheaper than an MR scan. And of course, the reimbursement is less in terms of what the patient has to pay. Where MRI has the advantage is MRI is going to give you a more comprehensive field of view. The way I kind of compare it is if you had a dark room and you had an ultrasound scan, that's the equivalent of walking into that dark room with a flashlight. And you're kind of looking around the room with this little itty bitty flashlight, trying to get a full assessment of the room that you're in. MRI is different. MRI is if you were to walk into that same dark room and just hit the light switch and all the lights go on, you could see everything in once. So it has that advantage. The other advantage that MRI has is for deep intra-articular tissues and for bone, MR is far superior. In fact, you can't really assess bone at all or very, very limited with ultrasound. If you're going to go that route, you're going to be thinking a different modality like MR, CT, or an X-ray. Okay, bone marrow specifically, MR is the gold standard for imaging that stuff. And then again, MRI is significantly less operator dependent. Ultrasound is operator dependent and it takes time from your perspective. You kind of blend it into your evaluation of the patient, your physical examination, but it does take some time, especially if you're new to the modality. Trying to scan somebody might be a little more difficult instead of writing a script for an MRI and having the MR tech run through and you get the entire study. Okay. There are a wide variety of ultrasound machines. This one on the left is actually the exact machine I trained on, which is fantastic. The resolution that I see is wonderful. And way back when, it was a long, long time ago, over 10 years ago, where I started playing around with it, these portable machines were like a no-go. Don't waste your time for MSK ultrasound using those. In the last few years, I think the technology has improved and it's going to continue to improve where those handheld machines might actually be beneficial to bring into your private practice once you get comfortable with the modality, if you were going to go down that route. So why would you choose ultrasound? Big reason is cost. This is a retrospective study where they looked through just over 3,500 MSK MRI reports, and they noted that just under half of the primary diagnosis and about a third of the secondary diagnoses could have been made with musculoskeletal ultrasound if it is indicated. And when you were to go through and substitute ultrasound for an MRI, it could lead to a savings of almost $7 billion. And that's a lot of money. And once insurance companies start seeing that kind of money, they're going to be more inclined to pay for the ultrasound over the MRI. The trouble is the lack of practitioners, certified musculoskeletal ultrasound practitioners that do exist, and the amount of research behind it, whether they're going to support that or not. But it can be a cost-saving measure in the long run, just something to keep an eye on. Okay. Accuracy. This is an article that was looking at rotator cuff disorders specifically, which is kind of MSK ultrasound's bread and butter. That's where it really shines in terms of research. And they compared ultrasound to MRI to MR arthrography in the evaluation of rotator cuff disorders. This was a meta-analysis. And what they went through about 2,300 articles, and they utilized 82 of them that met the criteria. And what they found was, let me get to the next slide here, that in terms of rotator cuff partial thickness tears, MR arthrography was slightly more sensitive than MRI and ultrasound. When it came to full thickness rotator cuff tears, all three modalities were equal. MRI, MR arthrography, and ultrasound had the same sensitivity and specificity. But the difference is ultrasound is cheaper. It's easier to acquire. You could do it in your office. You don't have to send the patient off to a different imaging center to get the study done. So that was the benefit in terms of a full thickness rotator cuff tear that ultrasound did have over MRI or MR arthrography. Okay. This is just kind of an example of where that dynamic capability that ultrasound has is beneficial. This is out of the North American Journal of Sports Physical Therapy. This was a collegiate baseball pitcher who was obviously working out, practicing, throwing the ball. He felt a pop in the medial aspect of his elbow. And clinically, it's an ulnar collateral ligament tear. We just know statistically, when you're dealing with a throwing athlete, that UCL at the elbow is just prone to tear. Okay. What they found was on this particular patient, x-rays and the MRI were all read as normal. So what they did was a dynamic assessment of the ulnar collateral ligament using diagnostic ultrasound. So what they did is they put the patient in this particular position here where the arm was up overhead and the ultrasound probe itself was placed on the inside or the ulnar aspect of that elbow. And then they did a procedure called the milking maneuver, which you guys are from Wisconsin, so you should know all about milking and cheese and cows and all that. But apparently they were pulling on his thumb like you would the udder of a cow. And what it was doing was providing a valgus stress at the elbow. And during the scan, you were able to see this little sliver of bone, which is a little avulsion at the insertion on the distal aspect of the ulna, which proved objectively through imaging that this poor pitcher had an ulnar collateral ligament tear that was negative on every other imaging modality. It was only seen because ultrasound provided the dynamic capability to stress a joint while the imaging was actually going on. So that's an example where ultrasound was helpful in this particular situation. I do have a few videos showing you what an ultrasound looks like in terms of a dynamic assessment. So if we look up here at the top, we see sort of this little cartoon image, but this green rectangle is where the ultrasound probe would be sitting. You could see on this side, you have the coracoid process coming off the scapula on the front. And then here we're at the lesser tuberosity right there. Basically, we're scanning across what would be the glenohumeral joint right there. And this is what we have here. This is the glenoid process. And this curvilinear area is the humeral head. And what you're going to see is I'm going to take internal rotation. And what it's going to do is this is your subscapularis tendon. And we could see it right where it's starting to turn into muscle fibers here. But as it's internally rotated, you'll see the actual insertion of the tendon come into view. And it's not going to work when I have a laser pointer on. So here we go. So that is showing you what it looks like when you pull, all you're doing is internally rotating at the glenohumeral joint, and then it's allowing for complete evaluation of that subscapularis tendon. And actually, what is pulled into view at the very end of it is the biceps tendon right there. So this is the distal aspect of the subscapularis tendon coming into the biceps tendon, and then we see this portion of the biceps tendon, the long head, as it goes through the bicipital groove. And you see that overlying retinaculum right there. Okay, another area that is easily evaluated with the dynamic component is subacromial impingement, which might occur. So if this is the top of the shoulder, this is our acromion process here. And you can see the tendon of the supraspinatus. The blue rectangle is showing you how the ultrasound probe is sitting. One half of it is on the acromion process, and the rest of it is showing you that supraspinatus tendon. So if you look down here at the scan, this is the top of the acromion process. We don't see anything underneath it because the ultrasound waves are blocked by the acromion. So this is just nothing. But what we are able to see is the edge of the acromion process. And then this is the supraspinatus tendon. So while the probe is sitting there, you have the patient just fully abduct their shoulder. And what you end up seeing is this. You see the very terminal end of the subscap right there. This is the overlying deltoid muscle, and of course, subcutaneous fat and then skin. But if there were like a subacromial bursitis, or if there was any kind of impingement, you would see approximation with the acromion in relation to the humeral head, and you might see some damage to the supraspinatus tendon as it's being pulled backwards. Okay. Okay, the last slide, this is at the posterior aspect of the shoulder. Here we have the infraspinatus tendon coming up, and what we have here is the probe sitting right here, looking at the posterior aspect of the glenohumeral joint. So as we go down here, this is the glenoid process. That's going to remain stationary during the dynamic testing. But as you're turning the humerus, this is the humeral head. So you're going to see this portion spin. And what you see here is the infraspinatus coming up in that direction. And you could see the posterior glenoid labrum right there. So let me show you that. And you could see that infraspinatus tendon get pulled into view. Right there. This is the glenoid labrum right there, and then the glenoid process and the humeral head and more of the humerus itself. Okay. As I'm going through this, if you guys have a question, feel free to just unmute and shout it out, and I'll try to get to it. Okay. There's always the question, because I get this asked a lot professionally, what study do I order? I have this patient with these symptoms. What would be the best imaging modality? I always refer people to the ACR appropriateness criteria. When it comes to musculoskeletal ultrasound, this is the third iteration of this particular article, but it's a Delphi committee. It was basically a committee that was set up of European radiologists, all of whom are very, very familiar with musculoskeletal ultrasound. And what they do periodically is they go through all of the research that's out there. And as they go through the research, they grade the level of research that exists. Grade 0, ultrasound is not indicated, all the way through grade 3, where ultrasound is the first choice. Okay, because other investigations rarely provide more information. All this is based on a combination of the research that they find and their clinical expertise, having done this for a long time. Okay. In terms, you guys did get a copy of these notes. I don't want to sit and read these to you because we don't have a lot of time. But you could see there is a lot of tendon, ligaments, subcutaneous subcutaneous palpable masses, foreign bodies. And the other thing, things like carpal tunnel, nerve compression syndromes are big with ultrasound. Okay. It's enormously beneficial when looking at the fingers. Okay. Around the elbow, again, nerve entrapment syndromes, as well as inflammatory tendon, inflammatory ligamentous type injuries. Okay. Again, the shoulder, big with rotator cuff tears, long head of the biceps, tendon dislocations or ruptures, inflammatory arthropathies. What you'll notice is there's not a lot with the shoulder. It's all the superficial stuff. The reason is ultrasound is limited as to how deep it could actually image into the shoulder. And depending upon the size of your patient, it might be difficult to get down in there. Versus things like the ankle of the foot or the wrist and the hand, everything is more superficial. So you're more likely to have a more thorough evaluation of the joint itself. Okay. So, and the hip is another one that's actually really, really difficult. Just because of the size of the patient and how deep it could actually, the ultrasound waves could actually penetrate down to evaluate things. It's more superficial structures that you are going to be looking at. I'm going to run through really quickly what normal tissue does look like on an ultrasound scan. Tendons, that's a big one. Here is the patellar tendon. We're looking at everything in short axis and long axis, which is essentially, you guys know this with imaging. When it comes to imaging, it's a two-dimensional medium and you're trying to evaluate a three-dimensional structure. And the only way that happens is if you have two orthogonal views to one another. In X-ray, you have an AP and a lateral. Without an AP and a lateral, without at least two views, you might as well have no views because you don't know what you're looking at. You can have you can kind of guess, but you really don't know. With MRI, we do sagittal and axial slices. With ultrasound, we do what's called long axis and short axis, which is essentially like a sagittal slice and an axial slice. A tendon is basically going to be these tight filaments packed together. Here we have the patella and the tibial tuberosity, and almost looks like a suspension bridge running right across it. That's the patellar tendon and long axis. We could see it from side to side. Then if we turn the probe 90 degrees, now we're looking at it sort of from an axial perspective right there. Now, if I take away the coloring, you can see what it looks like on ultrasound. A big thing with ultrasound is knowing where the probe is and what the anatomy is underneath it. Here's what the meniscus looks like. First off, the green is showing you over the top, the medial collateral ligament. And then this blue triangle is going to be the medial meniscus. This is the femur. This is the tibia over there. And you could actually see the anatomy. I got a wonderful example of a meniscal tear coming up in just a second. Here's another ligament, the coracoacromial ligament. Here's our acromion process. Here's our coracoid process. And again, like a suspension bridge, you see that ligament spanning it right across there. Had this ligament been torn, you don't see it in its entirety. If it's thickened or if the fibers look altered in any way, well, then you know there's pathology there. Muscle itself, we do short axis and long axis. When you look at a muscle in long axis, you see that central tendon and then the fibers going off in different directions. It almost looks like a feather. And then in short axis, it looks like that. You see that central tendon and then you see these little spots running through the muscle. They call it a starry night type appearance. But if you had any kind of muscle hematoma, muscle damage, central tendon tearing, anything along those lines, you're going to see alterations to the normal fibers that exist. Cartilage. This is if the knee is fully flexed and you have the ultrasound probe looking at that anterior cartilaginous layer of the femur. Just to kind of give you perspective, this would be the VMO sitting right there. But if I take away, cartilage should be pitch black like this. If this layer is not as thick, if you have little rents or defects or pits in there, then you know there's damage to that cartilaginous layer. Okay. Nerves. I did tell you that nerves are awesome to evaluate. People have gone through and mapped the circumference of nerves. When you have any kind of neuropathy, a compressive neuropathy, the nerve itself will swell under musculoskeletal ultrasound. So here we have the median nerve and short axis, and here's actually a nice shot of the sciatic nerve. Now, how do you tell the difference between a nerve and a tendon? Well, the nerve is not as tightly packed as that a ligament or a tendon are. That's one way. Another way is anatomically, where is it located? Nerves run in specific patterns. Tendons and ligaments are also anatomically located in specific locations. So that's why it's helpful with you as the practitioner doing the scan. You could see where that probe is at and you know what you're looking at. That's the median nerve. That's the sciatic nerve right there. Okay. So it's about 12:30 and I was going to start those cases. Did you want to take a break now?
Yes, Dr. Fergus, thank you so much. If you could click on your chat feature, we do have a question about the use for spinal
Okay.
imaging. Deanna, yes, if you could just bring up your slide presentation, we'll hear from SmartScan.
Okay. Find a demo, research trauma. Spinal musculoskeletal ultrasound, it's kind of difficult. I know there are people out there that are using it. There was a research project done at National when I was still there. They were trying to look at the facet joints and the facets, whether they're gapping or moving under ultrasound. And they were also trying to use it to try to detect where the they had vibrometers to see where the pop or that you hear with an adjustment was able to be picked up with the ultrasound. There's not a lot. Again, ultrasound can only go so deep. And the trouble with spine is a lot of the pathology is going to be blocked by a lot of bony structures. And because of that, it's difficult to see soft tissue things like maybe the ligamentum flavum, maybe if you had a facet cyst inside the spinal canal. You have to look for windows to actually go into that spine and actually see certain things. So it is difficult. Maybe one day, I know there are people that play around with it, but I don't think it's as established in the literature as it is with the extremities. I'm not sure if you found that helpful or not. That's kind of where it's at in terms of spine.
Perfect. Thank you so much, Dr. Fergus. Deanna, go ahead and bring up your presentation.
Right. Well, thank you for having us join today. Thank you, Dr. Fergus. So I am with SmartScan Medical Imaging. We're happy to be a corporate partner with the WCA. And at SmartScan Medical Imaging, we provide access to affordable, high-quality MRI services in an environment, independent clinics outside of the hospital. And we really focus, and our mission is to provide patients and their referring providers an exceptional quality experience and care when they're coming to our centers. And when it's indicated and utilized versus musculoskeletal ultrasound. So we have brand new GE Voyager scanners in all of our 3 facilities. They are located in Middleton, Weston outside of Wausau, and Eau Claire. And all of our machines are 1.5 Tesla. They are wide bore and have high field advantages. The newer equipment just allows the exams to be shorter and completed quickly. Patients listen to music on noise canceling headphones and to help reduce that noise. All of our sequences are done at an academic level standard that satisfies even the most demanding specialists and surgeons. And we have over a 99% completion rate with very few, less than 1% scans ever needing to be redone. And with that completion rate, over 20% higher completion rate than in open scanners in a study of over 700,000 patients. As I mentioned, virtually no repeated exams. If for some reason we needed to redo one, we would redo it at no charge to the patient. And when working with chiropractors, although it isn't exactly like a doc bar exam, our radiologists, when they see that they come from a referral is from a chiropractor, they will do a very highly detailed level by level radiology read report for that patient. And they're very consultative. If there were any questions, they field questions all the time from physicians to help answer any questions that they might have regarding the radiology read. All of our radiologists are employed by our organization and have a very fast turnaround time getting the reports back within 4 to 6 hours after completion of the MRI. A couple of things that we are doing that might not necessarily apply to chiropractic, but I like to show that we're trying to stay up and utilizing new technology and options is we are offering Cortex AI that we're using in volumetric brain analysis in Alzheimer's patients, traumatic brain injury, as well as multiple sclerosis and in some concussion. And then we started offering Ezra full body scan. That's a 30-minute or a 60-minute scan that scans for cancer, as well as over 500 other conditions. So really focused on trying to provide a great level of service for all of our patients. As I mentioned, we offer detailed reports. We have flexible options in terms of offering every major insurance plan. We have also options to work with legal, occupational, and accident victims to protect the patient's interests. And we have over 99% of our patients give us 5-star reviews for our exceptional patient experience, ease of scheduling, which is generally same day or next day, and the quality of images that we're giving back to our referring providers. We do work with our insurance companies to do the prior authorizations. As a preferred network and employer plan option, we make getting authorizations is relatively easy for us sometimes. Nothing is ever easy when insurance is involved usually, but we like to make that as seamless as possible for you and your patients. And then, like I said, we fax those reports within hours, and the images are available online through a portal to access, and we do send the patient with a CD of their images when they leave our facility. Again, thank you. We're here to be an option for your patients. We have a flat rate of $650 without contrast for all of our images, and it's $850 without contrast. All right, I will stop sharing and I will hand it back over to Dr. Fergus.
Awesome. Thank you very much. I need to. Can you guys see this?
Yes, we can see it. Thank you.
Awesome. Wonderful. So I have just a couple selection of a couple cases here that I wanted to share that sort of go through some of the areas where MSK ultrasound was, of use in clinical practice. The first one I have here is a shoulder exam. This was a 68-year-old male who had right shoulder pain and stiffness after a fall. So they took x-rays the next day, and then he got the ultrasound a while after that. So it started off with x-rays. And of course this is just a couple of the shots, but it's an internal and externally rotated shot of the shoulder. And of course we see pretty severe acromioclavicular arthrosis. We get these little cystic type changes, which suggest some degeneration of the rotator cuff. But there's no evidence of a fracture. There's no evidence of a dislocation, despite the fact the patient fell. You don't see post-traumatic pneumothorax, nothing that would be worrisome here. So apparently in the clinic, they took him through a course of care and were not having success. So instead of going for the MRI, they did go to the ultrasound. And this is what was seen on the ultrasound. Over here, this would be normal. And on this side was our patient, which is less than normal. What we have here is a normal supraspinatus tendon. We could see the supraspinatus tendon there. This little black line is a normal layer of cartilage along the humeral head. What we go over to our patient, where there should be a supraspinatus tendon, we have a big divot. And inside this big divot is replaced by this big giant area of void. It's just all black. On ultrasound, what black is like this, when it's this pitch black, is fluid. It's an effusion or an edema, and that's what's happening. This patient has a full thickness tear through the supraspinatus. Right there is about the insertion onto the greater tuberosity. So it's not exactly at the insertion point, but it's right over the top of the humeral head. So it suggests that not only was there a tear there, but there was retraction of the fibers as well. So being that this is a full thickness rotator cuff tear, this is probably going to end up being a surgical case for this particular patient. This is looking at the greater tuberosity. And remember, I pointed out those little cystic type changes that you saw on the plain film, where here they are in the ultrasound. Instead of this being like here, a nice smooth bit of cortex, what we have are these little divots inside that greater tuberosity. And this is just reactive intraosseous changes related to breakdown of the rotator cuff. So that lets me know not only does this patient have a full thickness tear through the supraspinatus, but that supraspinatus was probably not in good shape anyway, prior to it actually completely rupturing. And as we all know, you start to get into 70s, 60s, 70s in terms of patient age, everybody's rotator cuff is all beat up and shredded. It's a disadvantage of having such a highly mobile joint is we're going to tear that joint apart very, very early on. And I want to say you start to get to at least 50% of the patients by the time they're hitting 70 years old have some sort of significant damage to some of the tendons in the rotator cuff complex. Okay. This is another patient. This gentleman was 62 years old, and he described the pain as being identical to something that he experienced on the other side a few years prior. They did some orthopedic testing and it was positive for subacromial impingement and a supraspinatus tear. So that's what they expected going into the examination. And this is what they found when we were going through the examination. This is the ultrasound probe across the front of the humeral head. And what we see here is this little groove. This little groove here is the bicipital groove, where the long head of the biceps tendon actually travels down the front of the humerus. It comes off of the top of the glenoid process, sort of arcs around. You have an interarticular portion, then it wraps around and it dives through this little groove. Okay, and we see the overlying retinaculum intact over the top of it. And that's what we expect to see. Then we go to our patient and we have the bicipital groove. First off, kind of a mess, but what we're missing here, where is the tendon? Just don't see it. So we dig a little further and we externally rotate the shoulder, which is again one of the advantages of ultrasound. We externally rotate it, and in a normal situation you would put up the entire tendon of the subscapularis muscle. If the probe is sitting right here, when we turn our humeral head, we should pull more of that subscap into view and see the entire tendon. That's what we would expect to see. In our particular patient, we do not see the entire subscap. And then we have this oval lesion sitting right here. Well, this is normal anatomy. It's just sitting in the wrong spot. Instead of being here in the bicipital groove, it has bounced medially. What we have is a dislocated biceps tendon. So this was sent back to the surgeon, and the surgeon ordered the MRI because that's what they're comfortable with. And here, what this gave us was wonderful comparison between an MR and an ultrasound scan. So on the MR scan, this is that bicipital groove where you should have a little black tendon sitting in here, which would be the long head of the biceps tendon. But we can see the biceps tendon is sitting right here. It's dislocated, it's bounced out, and it's actually gone medial with respect to that bicipital groove. And this is the patient again, same patient, MR versus ultrasound. This is the empty groove, and we have the bicipital tendon sitting right over here. Okay, so this is wonderful correlation. In terms of biceps tendon dislocations, I've seen these a couple times, and I do know they can go and they could sit right here, which is probably the best case scenario. One of the worst case scenarios you could have is this thing actually dislocating and actually wrapping around and ending up in the joint, which could be very painful for the patient. And one case I did see while at a seminar was it actually went lateral and ended up behind the humeral head, which is kind of crazy to think about. So that tendon, when it does dislocate, it's not torn, it's just not running through the bicipital groove like it should, which suggests that the retinacular tissue over the top has ripped. It's torn, and now the tendon is free to move, and it could sublux, where it could bounce out and then bounce back in, or it could just completely bounce out and then it's not going to return. Another patient is a 54-year-old male, had left shoulder pain. This is actually the husband of one of the clinicians at National. He was having moderate shoulder pain after playing with his large dog. So the dog was pulling on the leash and he was kind of getting dragged with it. And he was experiencing shoulder pain after this encounter. He was having decreased range of motion. He was having painful flexion and abduction. And what we have here, again, the normal supraspinatus, as we'd like to see it. But what we have on this particular patient is this really, really bright line. And not only is it a bright line, but we don't see anything underneath it, which suggests to me that this is either ossification or calcification, because the sound waves are bouncing off of it. They're not going through it. What we see here is reverberation. You can see that. But this is calcification or ossification inside that supraspinatus tendon. And I actually have a video here. And what we're doing with the ultrasound is we're sort of letting it glide along from the supraspinatus down to the infraspinatus. So sort of starting at the top of the shoulder and working away from the top and then down. So right there is the supraspinatus, and we have that calcification right there that's not allowing us to see the rest of the tendon. But then we get by the supraspinatus, and you're actually going to see the infraspinatus come in nice and clean. We get by it, and then we have a perfect infraspinatus. So it's like a little movie. We scan through one tendon to the other tendon, and we could see it change from the pathologic condition with the calcification inside the tendon to the next tendon that's adjacent to it being normal. Okay. So what we did in this particular case is we got an x-ray because we wanted to see it. And here's nice correlation with this patient's x-ray. And we could see right here in the supraspinatus, you have this globular calcification. And as we all know, if we remember from our radiology classes, that is a classic example of HADD, or hydroxyapatite deposition disease. It's essentially calcific tendonitis inside our supraspinatus tendon. Does have some other complicating things, like some pretty significant acromioclavicular arthrosis, a little bit of a decrease in this subacromial space, suggesting that there might be a subacromial impingement in addition to some rotator cuff damage. But that's the big thing that we can kind of correlate with the ultrasound, is this glob of calcification sitting inside the joint. Okay, a couple knee exams that we did. This is a 42-year-old male that had infrapatellar pain. He's had a recent increase in his workout intensity. And what we're doing is looking at the patellar tendon. In this particular case, this is that normal patellar tendon, like a suspension bridge with nice, tightly packed, organized fibers. With our patient, as we get towards the patellar side, which is right here, the tendon is significantly thickened, and the pattern inside the tendon is fairly irregular. If we do a short axis, or essentially an axial cut, this is what we'd normally expect to see the patellar tendon looking like. When we get to our abnormal tendon, which was our patient, this portion of the tendon looks okay, but right when we get to the center of the tendon, it is thickened and irregular. You can even see the bowing of the soft tissue above right there, as well as bowing of that infrapatellar fat. We added color Doppler, and what color Doppler suggests is that there's neovascularization or hyperemia. This thing hurts. Patient could tell you that from a symptomatic standpoint, but now we have objective confirmation of it as well. Right in the area of that thickened tendon with the irregular fibers, we see all these flashes of new vascular supply. Okay. Another knee exam, this case I like a lot because there is MR correlation. This is just above the patella in that suprapatellar recess. You could see it right here as long axis and then short axis. And what we see is this big dark spot. That's all fluid. That's an effusion. And as we know, when we get a giant effusion in the knee, it likes to go to that suprapatellar recess. It goes to the path of least resistance, and that's one of the paths of least resistance, is in that suprapatellar recess. When we look at the back of the knee, right at that posteromedial meniscus, the posterior horn of the medial meniscus, this is the femur, this is the tibia, this black line is hyaline cartilage, but what we'd like to see here is a gray, nice, solid triangle. But we don't have a nice solid triangle. We have a defect running right through the center of it. That is a meniscal tear. This is the same patient, got an MRI, and right here in the posterior horn of that medial meniscus, right there is that defect. So we're able to see that meniscal tear pretty cleanly using the ultrasound. Here's the lateral aspect of it. You could see this irregular complex tear involving the body of that medial meniscus. And then you can see here a lot of irregular tearing through the body of the medial meniscus. Femur is right here. Tibia is right there. And then, of course, this is that suprapatellar effusion. You could see it right there. Foot and ankle. These are my last two cases, and then I will get you guys back to work. 29-year-old female, severe left lateral ankle pain. She fell down the stairs. And what we wanted to look at was the ATF, because she had a significant ankle injury. And what we found here is, instead of seeing a nice clean ATF, we see this little sliver of bone has avulsed off of the talus. So she had not only, she severely sprained her ATF, and she had actually avulsed a portion of the talus right off of the bone there. And then the last case I have for you, this is a 25-year-old female, ankle sprain. They didn't get an x-ray right away because she didn't meet the Ottawa ankle rules. She could bear weight through it. Palpable areas were not reported as not being tender. Honestly, off the record, I don't know how they missed it. But where we were looking is right at the styloid of the fifth. We were looking at the peroneus brevis tendon, which is this structure right here, which we have labeled PB on the study. But then this is that fifth metatarsal. That's the styloid process. And this is the rest of the styloid process. And what we had here was a defect running right through it. So we were suspicious for an avulsion fracture. So of course we moved the patient right to an x-ray. And look at that right there. If we were to zoom in on it, the patient had a small avulsion fracture at the tip of the styloid process. And I wonder if the clinician in question was actually palpating here and not so much here, which is why the Ottawa ankle rules were reported as negative, despite the fact that this patient had a fracture. So one of the things I wanted to say kind of in summary, I know we're sponsored by an MRI company. MRI is a wonderful tool. I don't want to misinterpret that and say that MRI needs to go away and ultrasound is going to replace it. That is absolutely not the case. MRI is not going anywhere. It's too valuable of a tool and we need to utilize it all the time in practice. But another viable imaging modality that does exist for a variety of reasons is MSK ultrasound, and you shouldn't overlook it. If you're looking for nerve compression studies, if you train in ultrasound and bring it into your practice, I've had it referred to as the orthopedist's stethoscope, which is kind of a nice example of it. You have a patient come in with an ankle sprain, you could very quickly assess maybe the ligamentous restraints along that lateral aspect of the ankle. You could look at that rotator cuff. You could look at things very, very quickly in office as a screening tool. And if they are suspect, then you can send them out for the MRI. So it's a wonderful tool when it is used properly. The biggest thing is it does require training. Okay, if there ever is any interest, I know Logan has a program where you could train in it. If you feel like it's wintertime, you could head down to St. Petersburg, Florida. There's the Gulf Coast Institute of ultrasound education that exists down there. And I'm going to stop sharing because that was my last slide. Or